Yeah, you are, ma'am.
Being recorded.
Okay.
Dr. Bindiya, 7 o'clock.
Okay, so we shall start now. So Dr. Sabui, I'll start, okay?
Let's unmute.
Take.
So good evening, everyone, for this very exciting ISCCP webinar, which we have on the 7th of every month at 7 p.m. for 70 minutes. And today we have a very important topic addressing HPV vaccination, and we'll have a talk followed by a panel. So before any further delay, today's convener is Dr. Subui Qureshi, and well-known gynec oncologist in Lucknow. And I'll hand over the mic to her, and the master of ceremonies, Dr. Sushma. So over to you, please.
Dr. Soumya.
Dr.
So
Soumya.
thank you, Dr. Bindiya, for giving us the opportunity for conducting this month's 7th February webinar, which is, as you told, on a very important topic. So without wasting time, let's go, and I'll hand over the mic to Dr. Soumya for conducting the event.
Thank you, ma'am. So a big welcome to everyone, our esteemed faculty and all the guest speakers for today. So today's webinar is meant to focus on the updates of HPV vaccination. So I encourage everyone to engage, ask questions, and learn from our leaders. And your presence and expertise are deeply appreciated. So welcome again, and we'll start the session. So I would like to call upon the chairpersons for first session. I'll start sharing the screen. So our chairpersons for today, is my screen visible?
Yeah.
You can make it full screen. Yeah.
Yes, ma'am. Is it full screen, ma'am, now?
No, it's
No.
no, it's not.
Please go to slideshow mode. It's just there.
Yeah.
Yeah. Yes.
So our chairpersons for today are Professor Uma Singh ma'am and Dr. Leela. So I would like to invite Uma Singh ma'am. She is a Senior Technical Director, University of Manitoba, ex-HOD and Dean KGMU Lucknow, WHO Fellow in Gynae Oncology, President of UP State Chapter of Association of Gynae Oncologists of India from 2019 to 2021, and Vice President of AGOI from 2017 to 2019. Dr. Leela, she is a renowned gynae oncologist at St. Teresa Hospital and Ashwin's Hospital, Hyderabad. She is immediate past president, Indian Society of Colposcopy and Cervical Pathology. She is a certified colposcopy trainer by ISCCP and master trainer of colposcopy workshops. She is invited faculty for ISCCP, EOGIN and AGOI National Conference and World Congress of IFCPC, Colombia. She is a DNB teacher and examiner for over a decade. She is involved with several NGOs for creating awareness, vaccination, and screening for cervical cancer with regular camps in North Andhra. And she started the program of Screen the Mother and Vaccinate the Child for cervical cancer elimination, which has covered 9 villages school. Welcome, ma'am, Dr. Leela and Dr. Uma Singh, ma'am.
Dr. Leela, I request you to introduce Dr. Abraham.
She has joined, ma'am.
Yeah, she was there. We just talked. Did you see Uma Singh, ma'am? Yeah, Dr. Leela is there.
Yes, ma'am, she's there. Dr. Uma Singh ma'am was there initially, I think. Should I
Dr.
call her?
Okay, what you can do is maybe introduce her and then we can go ahead.
So our respected speaker for today is Dr. Abraham, sir. He's a well-known personality. He needs no further introduction, but I'll just mention a few words about sir. He's a senior consultant gynae-oncology at Naruvi Hospital, Vellore, India. He has multiple memberships of SGO, IGCS, IAGE, and FOXY. He's past president Agoy and Neogen India. He's a senior consultant at SQ, CCC, and RC Muscat, Oman, professor and head of gynae-oncology, CMC, Vellore, India, and professor and head of OB-GYN department, CMC Vellore, India. He has more than 110 publications to his credit. Abraham, sir, over to you. I'll stop sharing.
Right. Thank you for that introduction and inviting me to. Sorry. I think the wrong one. Wrong one. 1 minute. Sorry. I think I
Yes,
clicked
sir.
on the wrong. To stop sharing. Okay. Can you see my screen? Can you see the slides?
Yes, sir.
Okay, so thank you, ISCCP, Professor Nigam, Dr. Vindhya, and the others, Leela. So I was asked to talk for about 20 minutes on some aspect of HPV vaccination. So I think the program says it's a plate of some new aspects. Just to set the background, the trends in cervical cancer have coming down in most countries. Maybe in some of the African countries where there is HIV prevalence, it may be going up. But in India, it's been coming down, and we are now standing at around 14, 15 per 100,000 women per year. However, we still have a very high disease burden, and we still contribute 127,000 cases every year of cervical cancer, and we contribute about 25% of deaths due to cervical cancer in the world. Now, the dual strategies for eliminating cervical cancer are: one, primary prevention through HPV vaccination, which removes the causation, that is, prevents HPV infection and therefore prevents pre-cancer and cancer. The other strategy is cervical cancer screening, and both have to be done together. And so early detection and curative intervention at the pre-cancer stage will prevent progression to cancer. And this is very cost effective and among the highest bargains in non-communicable disease interventions. Now, the concept for the prophylactic HPV vaccine, now neutralizing antibodies are directed against the HPV L1 capsid protein in the native conformation. HPV cannot be grown in bulk in culture. So traditional virus vaccines made from live or killed virus are not possible. Prophylactic HPV vaccines are subunit protein vaccines comprised of the L1 protein assembled into virus-like particles. These are empty protein shells that are not infectious, but they are highly immunogenic. Now, how do prophylactic HPV vaccines work? When we have, after 2 or 3 doses of HPV vaccine, we have very high antibody levels, and these antibodies exude from the circulation and prevent HPV from binding to the host cells of the anogenital epithelium. And it also directly inactivates the virus. After a single dose, sometimes you have lower antibody levels, yet they do work. And the mechanisms other than neutralization are antibody-dependent phagocytosis, degradation by activated neutrophils, and antibody-dependent cytotoxicity. Now, the evidence for vaccine efficacy has well established from several randomized controlled trials. And this slide shows you the results from the Costa Rica trial, the Patricia trial, and the future 1 and 2 trials. And if you look at the vaccine types as well as the non-vaccine types, the efficacy in terms of CIN3 and CIN2 are all about 90%. If you look at the right extreme, the future trials for CIN2, it is 98%, and CIN3 plus is 97%. So these are very efficacious vaccines. Now, what do we mean by vaccine efficacy? If a vaccine has an efficacy of 80%, it does not mean that the vaccine will only work 80% of the time. What it means is that in a vaccinated population, 80% fewer people will develop or will contract the disease when they are come in contact with the virus, as compared to those who are not vaccinated. So the vaccine effectiveness is given by this formula: unvaccinated rate minus vaccinated rate divided by the unvaccinated rate, or 1 minus 1 upon relative risk. So in India, if we say we have a incidence of 14 per 100,000 women per year, then with the quadrivalent HPV vaccine, assuming 70% efficacy, incidence should come down to 4 per 100,000, which is the target set for elimination. And the number needed to treat or to vaccinate to prevent anogenital warts is 9 women, 9 to 26, for high-grade lesions 22, and for cancer 202. If you look at the cost effectiveness, if you vaccinate only girls, it's very highly effective. By on the x-axis we see the different strategies, and on the y-axis we see the cost effectiveness in $1,000 per quality adjusted life year. And by convention, anything below $50,000 is considered very effective. And if you have the price of the vaccine comes down lower, it's going to be a very, very effective strategy. Now, what are the recent developments in HPV vaccination? The approval of the Serum Institute of India's quadrivalent HPV vaccine, Servavac, which is compared to quadrivalent Gardasil. And the manufacturer has committed to eventually produce 100 million doses annually. Now, the WHO has recommended off-label single-dose schedule of vaccines that have shown efficacy from single dose or have had immunobridging trials show that a single dose is quite effective. And ICMR has initiated a non-inferiority trial of single-dose Servavac versus Gardasil in, I think, 4 centers. I think AIMS is one of them, and 3 other ICMR centers. Results are expected in 2027 or so. Now, what are the available HPV vaccines? We have the Cervarix, which is the bivalent vaccine from GSK. We have the Merck's quadrivalent Gardasil, and we have Gardasil 9, also from Merck. Then the Secolin, which is a Chinese vaccine. Volrinax is also a Chinese vaccine. And now India has got the Servavac. And the various vaccines are compared in this table. And all of them were initially licensed for 2 or 3 doses, but 3 doses, but 4 of the listed here, that is Cervarix, Gardasil, Gardasil 9, and Secolin, have now been approved for single dose. And hopefully in a couple of years, Servavac will also be approved for single dose. Now, this slide shows the cervical cancer incidence by, in different countries. In the shades of blue show the different age standardized incidence rates. The size of the box is proportional to the number of annual cervical cancer cases. So you see that India and China have the largest boxes. And here the vaccination is self-financed as of now. The yellow arrows show that countries with Gavi assisted programs. And on the right-hand side, you have the countries where national vaccination has been introduced. And the different shades of violet indicate the coverage of the HPV vaccine. The higher the shade, the darkest boxes are more than 80%, and the light boxes are less than 50%. Now, the WHO targets, we have seen this slide ad nauseum, but just to say that the vision is a world where cervical cancer is eliminated as a public health problem. And the goal is less than 4 cases of cervical cancer per 100,000 women years, new cases per 100,000 women years. That is the cutoff we have taken for elimination. We are not talking of eradication, but elimination. And as far as vaccination is considered, by 2030, 90% of girls less than 15 years of age should be vaccinated. Now in India, there are 12 million girls are born every year. So that we need to, if you're going to vaccinate 9 to 14, that are 6 multi-age cohorts that have to be vaccinated every year. Now, how are we doing? Australia is one of the first countries that really pushed ahead with both screening and vaccination. And this is what they are tracking what they are doing. So HPV vaccination, as of now, already more than 85% have been vaccinated, both boys and girls. And the goal is 90%. So they'll get there very soon. And as far as screening and treatment is concerned, also they are doing excellent. Whereas where are we? We are somewhere right in this left corner. We're just about starting. So, and we don't have much time. So I'm not sure when we are going to reach this goal. Now, this is one of the strategies that has been, some of the strategy, HPV faster strategy to eliminate the cervix that's been advocated a few years ago. Basically, generalize vaccination for adolescent girls at 9 to 14, then extend the vaccination, both catch up as well as the age group can be extended, and even taking it to beyond 26 years, so up to 45 years or so. And we can combine that with screening. And also in the blue, you see the male vaccination. So if the coverage of girls is less than 70%, one strategy is to vaccinate boys as well, so that herd immunity is achieved. Now, this is about the single dose vaccine. So several trials and also observational studies have shown that single dose does produce adequate antibody levels that last for more than 10 years. Now, these are two randomized controlled trials. One is the KENSHI, which was the Kenya single HPV efficacy trial in girls 15 to 20 years, and the DORIS trial, which is a immunobridging trial of dose reduction of immunization schedule 9 to 14 years in Tanzania. And you can see for both HPV 16 in the brown and HPV 18 in the blue that adequate antibody levels are reached. So there is no prescribed antibody level. We don't know whether there is one. Even low levels of antibody are effective in preventing HPV infection and CIN. But this study has shown that more than 10 units per ml is more than sufficient. So both for Cervarix and for Gardasil 9, the antibody response with a single dose, this is 24 months after single dose, has been shown. This is the ratio of the geometric mean concentrations at 24 months after a single dose of HPV vaccine, comparing the, again, we have the HPV 16 and 18 for the two vaccines, Cervarix and Gardasil 9. And here we have the ratio of DORIS to KENSHI. And for Cervarix, it's both Cervarix and Gardasil 9 are on this side of the non-inferiority margin, which is shown here. So both are effective, but higher antibody levels are produced with the Gardasil 9 as compared to Cervarix. Now, the WHO recommendation is HPV vaccination for all girls to prevent cervical cancer later in life, 1 or 2 doses. So they have not committed to 1 dose or 2 doses. And for immunocompromised and older women, it is 2 or 3 doses. Now, so advantages of the single dose is that it is less expensive, whether it be out of pocket or by the government. And when we are talking of the situation in India, we are talking of millions and millions of doses. So it's going to be a very big commitment to the government. Although they have agreed to it in principle, they have not put the money where their mouth is. A single dose will be programmatically much simpler to implement. We don't have to follow up with girls. We can, just take a certain age group or certain class, a school class, and immunize in that way. The supply demand problem would also be eased and solved to some extent. The problem is in the whole world, we don't have enough vaccines. Even in India, Serum Institute is promised to produce 100 million doses per year, but right now they are nowhere near that. So it makes sense to go with a one-dose policy. Now, this is a map showing the coverage of at least one dose of HPV vaccine. You can see that in the dark green, it is more than 90%, whereas India is violet, which is we just initiated, and we really don't have much data here in the gray and the violet. And in the yellow is less than 50%. So many of the African countries are getting there. South America and America, Europe, Australia have done very well, and the Southeast Asian countries. Now, NTAGI has met. That's an advisory group for the government of India, has recommended that one-time catch-up single dose for girls aged 9 to 14 be given, and routine 2 doses of vaccine at 9 years. So this is their recommendation. They have still, because they are talking of the Servovac, they have still, as of now, recommending 2 doses. Now, what is the rollout plan? I mean, if you are now looking at state level or district level or national level rollout, as per the estimated number of girls and the number of doses required, if you are giving, it's the number of in each year. If you say we do it in the next 3 or 4 years, we plan to immunize all these girls in this age group, we are going to require this many doses. So in first year itself, we give it to the older girls. We need 48 million doses. Second year, we give a few 9-year-olds, and the ones older girls, 56 million, and so on. The third year, 64 million, and after that, every year, 24 million doses. Now, the different strategies have been suggested. One is introduce a 2-dose schedule for only the oldest eligible age cohort. That is, you give it to only 14-year-old girls to begin with. So, because they are the ones who are going to get pre-cancer first. They are the ones who are going to get married first or have sexual activity first. So give it to the 14-year-olds if you don't have enough money or if you don't have enough vaccine. Strategy 2 is to use a 2-dose schedule with smaller multi-age cohorts. That is, instead of covering 6 eligible cohorts, that is 9, 10, 11, 12, 13, 14, you give it only to 12 to 14 or 13 to 14 to begin with, and then maybe offer it to the others. The third strategy is use an extended interval strategy. That is, vaccine effectiveness is maintained through a 3 to 5. We know that antibody levels are maintained. So we can give 1 dose now, and we'll wait 3 to 5 years and see whether we can give whether a second dose is necessary or not. If the ICMR single dose study shows that 1 dose is enough, then we don't have to give a second dose. So the number of doses required would be halved if we use just the 1 dose. This is just to show the vaccine requirements in millions of doses, the alternative strategies. So what the NTAGI has recommended, that is a 2-dose, what they've recommended is in first year, second year, 3-year rollout. These are the number of millions of doses required. If we do the only 14-year, it's much less. If you do only 12 to 14 years, again, it's a little less. 3-year interval, it would be even less. So the total number of doses, if you follow NTAGI recommendation, we'd require 168 million doses in the next 3 years. Whereas if you do this extended interval, we could probably stop after a single dose, we would require only 84. Or if we do it only for 14-year-olds, we need 48 million. So those who are in the policy planning and health department, government planners will have to take this into account. And also the cost of the vaccine. I mean, if Servavac gives it to the government at 500 rupees per dose, that would be good. But in private, it's almost 2,000 rupees per dose. Now, these are showing the different strategies, the age cohorts that we are doing, and the number of years it will be taken to finish vaccinating the intended cohorts. And the number of cancers prevented in millions is almost the same with all these different strategies. So the public health perspective, I mean, all of us are clinicians, most of us are clinicians, and we are just working in the clinic, and that's a different perspective. A woman comes to us with a mother, daughter, those who have had cancer or pre-cancer, we talk to them, counsel them about HPV vaccine. That's one thing. But really, if you want to make a dent in the country, we have to do it at district level, state level, and the national level. And so HPV vaccination in India is a public health imperative. And at least 70% of girls 9 to 14 years should be vaccinated. The rollout of the vaccine will depend on the cost of the vaccine and also the availability. Various strategies like we have looked at, that is staggered vaccination or single dose vaccination, have been suggested. And school-based vaccination has stood the test of time. So probably we could just, if you decide on the 14-year-olds, just give it to 14-year-olds who have gone to school. At probably what class would that be? Maybe 8th graders or so, 8th or 9th graders. Take-home messages. Single dose is effective for at least 10 years, maybe more. India now has the Servavac, which is Serum Institute's quadrivalent vaccine, which has been licensed for 2 doses below 9 to 14 and for 3 doses above 15 to 26. But we await the results of the study looking at single dose vaccine. Vaccine can be given from age 9 to 45, that is the extended age group, in the clinics, but the government should really concentrate only in the 9 to 14-year age group. Maybe even just the 14-year age group, because they won't have the money to give it to everybody. As of now, the 9-valent vaccine is the best available. And the efficacy it's effective against almost 90% of infections that can be prevented. Now, the 11-valent and 14-valent vaccines are in development. People are looking at that, but as of now, they are not in the market. Gender-neutral vaccination could be considered if resources are available and if coverage of girls is not adequate. Now, the prophylactic HPV vaccination can be given to patients with warts, HIV, and CIN, but of course, the efficacy is going to be much less, probably drop to 40% or 50%. And we await the development of therapeutic vaccines for these patients. Thank you. So, to achieve the WHO goal, we need resources and political will. Vaccination and screening are the sure defenses against cancer cervix. We have miles to go before we sleep. And I'll stop here. Thank you.
Thank you, sir, for this very informative talk.
We would invite
Is there a question to answer?
the experts for their comments. Uma Singh ma'am is there, and Dr. Leela is also there.
So, good evening, everybody. I mean, who is an expert after what Dr. Abraham is talking? So that doesn't. But what I really liked, hello, Dr. Abraham.
Yeah,
So
hi, Uma.
Hi. So what I liked was towards the end when you added the public health, the aspect, because it is so different to be sitting in a clinic and
Right.
talking to patients or having that small amount of medical college based, approach. Then those things are different. But coming to public health, things are really, really different. In relevance to India, one, universally, it has not been accepted in the immunization program. That is biggest challenge. Few states have made their own independent, small efforts. Some have been successful to some extent. Some have not been able to successful to quite some extent. And hence, for us to be able to do a community vaccination is something we hope to see in our own lifetime materializing, because we know whatever efforts, because screening in our country is also abysmal. All the efforts of trying to bring screening also meet all hurdles, all types of hurdles. In spite of all efforts, I think Tamil Nadu is at something like 6 to 8% of screening. UP is worse, about 2% or something like that of screening. So for long term, there is no doubt about it that vaccine is our hope. Hopefully, in coming times, we have universal approach and availability of really, really subsidized vaccine for that. What you suggested is very right. When the resources are not adequate, do not unnecessarily talk and advocate it to elderly population and 26 catch up everything. Please focus on just 13, 14, so that we at least are able to do. Of course, those who can afford are free to get. Thank you so much, Dr. Abraham. I think it's been a wonderful talk.
I think the government is, constrained by the cost, because enormous. If they say India's got a very good record for immunization. So I think it can be done. Only thing we have to find the money.
They have to find money. Vaccines would be available after, in coming years, vaccine would be available. The cost, even for the government, would be humongous. Humongous.
Dr. Leela, ma'am.
Yeah, good evening. Thank you very much for making me part of this wonderful program. It's always a pleasure to listen to Dr. Abraham, because the way he analyzes the topic, especially with regards to the public health issues and the cost effectiveness, it's wonderful to listen to you, sir. So as you have rightly said, yes, the problem is what I understand actually from the vaccination is, of course, as you said rightly, even though it is recommended, it is still not has become a public health program countrywide. And I do believe in this school vaccination programs, because we have done a few like that. The major problem what we have faced is the government's approval, because in the underprivileged in government schools in rural areas, if you want to do, you have to have lots and lots of permissions from the government, which we are not able to get, at least in twin Telugu cities. So we are ending up in doing programs wherever it is possible. So when the small private schools, when the management agrees, we are actually able to penetrate into those areas and do this vaccination program combining with the screening. But as you rightly said, I think most of us are clinicians, and when we are sitting in our clinics, I do see a lot of young women or women even beyond 40 coming and asking for vaccination. I think majority are doing that. So I don't know what's your opinion about this adult vaccination, rather than focusing on the right age or appropriate for age for vaccination, because many of our gynecologists feel that they are taken care by the pediatricians, but I do feel that we are seeing lots of adolescent population. So I'm not still convinced of doing vaccination for adult population, especially those who are married for a very long time and sexually active and other things, sir. So what's your opinion about that, sir?
Oh, the companies are pushing for this. See, they want to give it to antenatal, postnatal women. They want to give it for women up to 45. But we have to explain to each person that the efficacy is only maybe 40, 50%. That is, we are assuming that they have not been infected by HPV. There is a chance that they could have already been affected. So in which case, giving vaccine is unnecessary.
Yes,
so
sir,
we are
we try
wasting
to
vaccines there. And if you're looking at, if the government is going to start, there won't be vaccine for everybody.
Yes, sir, that's very
There
true.
won't be vaccine to give the older woman. That is
Yes,
one.
yes.
So second thing is, I mean, if in the clinic, the woman says, I've got the money, I want it, we can talk to them and counsel them and say that, okay, if you want it, take it, you take it. As of now, it's available in our clinic pharmacies, we give it. If they, but I always tell them that you must remember that you're paying 4,000 or 10,000 rupees for a vaccine that is going to reduce your risk from 14 per thousand to we don't they think it's prevent all cancers or there's no way they're going to get cervical cancer. So the genital cancer will come down from 14 per 100,000. That's why the vaccine skeptics say it is so uncommon. Do we really need to do it? So we
Yes,
have to make them understand the risk comes down from 14 per 100,000 to say 4 per 100,000 or 5 per 100,000. And are they willing to pay the 10,000 rupees at least 2 doses?
yes, sir. Yes, sir. That's a major problem. They say we are okay to pay and all. As you rightly said, we can't prevent them. If I don't give, somebody else would give it. But what I feel is the right age is not getting targeted. That's what my feeling is.
Yes.
And the target, what you have said, is very useful in the sense delaying the second dose. But again, keeping the track of those people to call them back for a second dose would be definitely a challenge. That's what I
That's why
feel.
I think single dose is the way to go. We have to do
Yes, sir. Yes,
government
sir.
should do single dose and to start with, 9 to 14 years. If you
Yes, sir.
can't do 9 to 14, at least 14-year-olds
Yes, sir.
or 12 to 14-year-olds,
Yeah.
something like that. We have to have some strategy
Yes, sir.
and I think we have to push instead of just giving it to the clinic, older women in our clinics, we should push the government. Those who have clout with the health department should say that, like some
Yes,
states
sir.
have started moving ahead, but
Yes.
it's easier said than done.
Yes, sir. That's true, sir. That's true, sir. So thank you very much, sir, for your wonderful lecture. And I think we are going to have a wonderful panel discussion, probably covering all these aspects. Thank you. Thank you, organizers.
So, thank you, Abraham sir. Excellent lecture, very crisp lecture. So, sorry to interrupt Dr. Subhuhi. As we discussed earlier, Dr. Aruna has now joined, and I would officially invite her to welcome all the dignitaries and to address the gathering. Dr. Aruna, over to you.
Thank you, Dr. Bindya, and it was a wonderful lecture, Dr. Abraham. And whenever we talk of a public health, we need to have a government initiative and policies. Only then any program can be rolled out. We are only the resources who can convince the government to roll out the programs. But ultimately, the policies and the initiatives of the government, only then it can be successful. Any vaccination. We have seen the polio how we could do it only because COVID vaccination, only because of. So we need to make them understand that this is a public health problem and we need to work on that. So with this, I just want to, every time I do few announcement for my ISCCP members, and again this time also I'm making few of the announcement, and this is going to be very helpful for you if you are thinking of attending the ISCCP Con 2026. So let me just share my slides so that you will have the overview of what we want to disseminate for our society, and everybody can get these informations from our website, that is isccp.in, which is freely available to all of you. So this time on the World Cancer Day celebration, we have announced two competition. One is a poster competition and other is the slogan competition. The poster slogan competitions both are open for a MBBS student and nursing students. And the slogan competition, especially this challenge is for the ISCCP members also, and there are attractive prizes, and the winner of this prize will get free registration for our annual conference. So last date of submission is 15th February. We have already sent bulk mail to everyone. I will request all of you to kindly circulate among your MBBS and nursing students so that they should also know what is cervical cancer and how we can eliminate if they are going to be involved with some kind of slogan and some kind of poster. This is first announcement, and the second is we are going to have our annual conference in Chennai on 27, 28, 29th March. So I invite all of you to come there, attend the interesting conference. We are covering all the topics of the cervical cancer, preventive methods, vaccination, and the part of the vulva also. Here, I would like to announce the initiative by Indian Society of Colposcopy and Cervical Pathology that we have started a travel grant in the form of the competition papers for ISCCP Con 2026. You can have this information also on our website where you can submit your full paper and win the prizes to attend as well as the grant of 15,000 each whosoever wins. So we have 7 prizes on in this category. So kindly go through it. If any problem is there, you can mail us at secretariat@icccp.in. Another announcement you must be seeing in our group that the International Federation of Colposcopy and Cervical Pathology is going to have their international conference in Paris in June 4, 5, 6. So we have planned a grant for attending the IFCPC conference also of 50,000, and complete detail of this grant can be obtained from our website on our ISCCP Academia section. So please go through the detail and take the benefit as the abstract submission date has been extended till 15th February. This is another announcement as we are finishing up with the first fellowship course, and right now exams are going on. We will be starting this FICCP next batch in the April. So the registration is open for this course. So all of you who are interested in applying for the fellowship, it is going to be a very intensive 6 months weekly training with the online plus offline method. So you can take the information from the website and apply online. Similarly, the course which we have introduced first time, that is a V-Insight course. This is a comprehensive course on vulvovaginal disorder for all of you. And this is one of the neglected areas by all the postgraduates and even by the junior and the senior faculty. So we have introduced, because I think the vulva, vagina and the cervix all are ours as a gynecologist, and we need to know the details. We don't need to go treat the vulval carcinoma, that can go to oncologist, but till the VIN, till the vaginal discharges, to understand the concept of the microbiome, itching, dermatosis, we all need to know and understand, because the patient is going to come to us first time. So this course, second batch, is also starting from the 10th of April. So you all can register for this course online and get the information on the ISCCP Academia section. This is your journal, our journal of colposcopy and genital tract pathology, and we have already had 6 issues already published. I will request all of you to submit the articles, review article, original articles to this journal, so that you can have a publication in your own society journal, which is indexed at many of the places. All the ISCC members who are listening to this can apply for the bid of the ISCCP annual conference. The mail has already been sent to all the ISCCP members who are interested to conduct an annual conference in 2027. So all the guidelines are there. You can apply for that. And this is all for you. I think I have made many announcements. Every information is there on the website, which is available to all of you. Please take a benefit. All the monthly webinars are updated on our website. So anytime if you want, you can listen to all these webinars which have been taken by the stalwarts in this field. So thank you all for patiently listening to all my announcements. So I will request now Dr. Saboyi to take over. Thank you, Dr. Bendya. Dr. Saboyi, you can start. Thank you.
Thank you, Dr. Aruna, for the announcement made, and I think they're very pertinent, and we should know. It helps us in enlarging our the available resources which are available to us, so that we can enhance our learning and enhance our skills. So thank you very much, Dr. Aruna, for giving us the opportunity for conducting this month's webinar. And we have already heard Dr. Abraham. And thank you, sir, for your very nice presentation, comprehensive, crisp, giving us all the bits right from starting, the information about HPV vaccination, how does it work, in what age groups, and the government perspective, and the application, and how will it actually, how many vaccines are required, from the implementation point of view. So thank you so much for giving us this information today, sir. And now I think, without wasting any more time, let's go on to the panel to actually discuss about all those points which sir has covered into the practical aspects. How do we apply them to our practical knowledge, and how do we apply them sitting in our clinics when we have situations? And let us go on to that. So Soumya, can you just put up the CV so that we can call the panelists?
Yes, ma'am. I'll start sharing. Yes, ma'am. So I'm starting the CVs of the panelists.
Yeah, so we have, can you just put them on full screen? Dr. Ruchi
Yes.
Pathak, who is a medical officer and officer in charge, Department of Epidemiology and Community Screening, in the MPMMCC and Homi Bhabha Cancer Institute, Tata Memorial Center, Varanasi. Very good evening, Dr. Ruchi, and thank you for joining us as our panelist. Next, we have
Thank
Dr. Manjusha, who is a senior consultant, OBGYN. She's associated with Max Super Speciality Hospital in Lucknow. Thank you, Dr. Manjusha, for joining us. Then we have Dr. Soumya, who is assistant professor in Department of Gynae Oncology, in my Department of Gynae Oncology in Kalyan Singh Super Speciality Cancer Institute. Welcome, Soumya.
Thank you.
Dr. Pratima Verma, who is Associate Professor in GSPM Medical College, Kanpur. Thank you, Pratima, for joining us. Then we have Mrs. Tanuja Jaiswal. She is basically a social worker and she's associated with Inner Wheel Rotary of Lucknow. And thank you so much, ma'am, for joining us today to learn from you for the perspective from your point about HPV vaccination. Then we have Dr. Alka Sharma. She is a senior public health leader with over 32 years of experience, and she is an additional director, Health and State Nodal Officer, NCD Uttar Pradesh. Thank you, Alka ma'am, for coming here and joining for the panel. So without wasting any more time, Soumya, can you stop sharing
Yes,
so
ma'am.
that I can share my presentation?
Has it stopped, ma'am? I stopped already.
Yeah.
Yeah.
So you can see my screen?
Yes,
Yes, ma'am.
Yeah. Full screen कर slideshow कर दीजिए.
Yeah. Done slideshow?
Yes, perfect.
Yeah. So welcome all to this panel. Let's go on to the. We've already heard about this portion from Abraham sir. We don't need to be here, and we know the most important thing which I need to emphasize here is that we lose about 8 women every hour, and one woman dies every 8 minutes in India. So if that's a huge number, which we lose young women to cervical cancer, and which we need to prevent this cancer. And in that goal only, we are discussing one of the HPV vaccination. How will it help us in containing the epidemic of HPV induced cervical cancer? So I'll just skip on to this and go on to, as sir has already given us the perspective, Dr. Pratima, can you tell us how does HPV vaccine work to prevent cervical cancer?
Sure, ma'am. Thank you so much, ma'am, for giving the opportunity. I would like to say there might be a question that why vaccine? Because what happens, our HPV infection itself gives very weak kind of immune response, because it only invades the basal layer. So, and there is only local place where it creates its damage, and it does not go into the blood. So, what our vaccine do? By Dr. Anne Fraser, who has invented this, what he did, he used virus-like particles, which two kind of initially there were two kind of the yeast cells, and baculovirus was used for creating these virus-like particles. And what they do, they are highly immunogenic. So what they do, they just accelerate our immunity, humoral and cell-mediated immunity, which helps in infection. And whenever, like already said by Dr. Abraham, it directly destroys our virus whenever it comes into contact of the patient which has already been vaccinated. And secondly, what it neutralizes these antigens, so that antigen antibody reaction which actually saves us. So this is the crux of it.
Yeah, yes, very rightly said. HPV infects the target cells in the basal layers of the cervical epithelium, and the neutralizing antibodies, they prevent HPV from infecting basal epithelial cells. So that is how the neutralizing antibodies are like a mediator of protection, which gives immunity. And this immunity is much stronger and is there for a longer time as compared to the natural infection-induced immunity, which is there, which is a shorter and a weaker immunity. So this is about the mechanism which you've already told us, Pratima. Can you tell us what are the different types of vaccines which are available in our country?
Yeah, sure, ma'am. India has approved in 2008 or I think 2009 for the vaccine in India, and initially there were bivalent, quadrivalent, and now we have nonavalent vaccine here in India. And initially it was Cervarix, then Gardasil 9, and we have now going to have Cervavac recently by Serum India. So in our Cervarix, which was bivalent, it covers only 16, 18. Then in quadrivalent, it covers 6, 11, 16, and 18. In nonavalent, in addition, it covers 31, 33, 52, and 58. So these are the available, and as sir has already said, presently nonavalent is the best vaccine available.
Yeah, so Cervarix to begin was with there in India, but now it has like withdrawn its market from India. So what practically we are aware, the vaccines which are available in India today are Cervavac and Gardasil 4 and 9, the quadrivalent vaccine and the nonavalent vaccine. These are two vaccines which are available in India with us for HPV vaccination. So Dr. Manjusha, can you tell us about the vaccination schedule? Dr. Manjusha?
Hi, thank you, Sabui, for making me a part of this wonderful webinar. And as for the schedule which we are following so far is for under 15s, we are following a 2-dose schedule, that is at 0 and 6 months. And for above 15, we are following a 3-dose schedule, 0, 2, and 6. So this is as of now.
Yeah, so we have a 2-dose schedule and we have a 3-dose schedule. In less than 19 years of age, 9 to 19, the 2-dose schedule is followed 0 and 6 months. And the more than 20 years till 45 years, the 3-dose schedule, which is there, 0, 2, and 6 months is what is followed. And Dr. Manjusha, in this connection only, Dr. Abraham also told us about this, the single versus 2 doses in less than 19 years of age group. The evidence, what does it tell us? About that?
Yeah, as sir has already told us very clearly that the WHO has now recommended a single dose schedule, and then it has been shown to be as efficacious as a 2-dose schedule. But of course, when we are dealing with people above 19 or the immunocompromised women or with HIV and transplant recipients, then of course a 2 or 3 dose schedule has been given. And the ICMR study is already underway, and we expect the results to be in by about another 1 year or so. So till then, I think we stick on to the henceforth recommended schedule. But yes, if not feasible, not affordable, somebody takes a single dose, we can be going ahead with that also, because as per the WHO recommendation, even a single dose is giving us reasonable amount of immunity.
Yeah, so very true. WHO has given this single dose recommendation about 2 years back, and NTAG in India has also given this recommendation to government of India, giving this one dose in the 9 to 19 years of age group. And recently, this was a original article in NEJM, the non-inferiority of one HPV vaccine dose to 2 doses. So we have a clear recommendation from this. This was a randomized control trial, a non-inferiority trial, which was done, and they clearly proved that one dose of HPV vaccine. I'm sorry, my screen has disappeared. Can you see my screen?
Yes, ma'am, it's visible.
Yes, we can see.
Yes, ma'am.
I'll just stop sharing and then reshare it. I'm sorry. So we have the clear recommendation which is there, and which says that one dose of either a bivalent or a nonavalent HPV vaccine provides protection against HPV 16 or 18 infection and was not inferior to 2 doses. And this was funded by the National Cancer Institute and others. And so this is, I think, will further reiterate our, and this would go a long way in, and can be easily now adopted in our vaccination schedule when the government introduces into the program of introducing single dose HPV vaccine in the 9 to 19 years of age group. So, yeah.
Yeah, I was saying that, as Sir has very beautifully said in his lecture also, that if one dose would make it financially more feasible and logistically more doable, if maybe it could be linked to all the high schoolers, it would be giving them very good immunity to those who really need it, the primary targets, as well as it would be easier and more financially viable for the government to be doing it as a public health program. Absolutely
sure.
agree.
Yes. So, another question for you, Dr. Manjusha, is HPV vaccine effective in sexually active persons? Because we often get in our clinics, as was discussed earlier also, that older women who are sexually active, more than 30 years of age, are coming to us and asking us for the vaccine. So, what is your take on this?
See, the vaccine is best given before the sexual debut. And especially as the adolescents, these girls are not monoandrous and monogamous. So it's better that we vaccinate them before they fall into this, not fall, before they indulge into this. But as for the older women, those who have already been sexually active, it is still of benefit to give them the vaccine, because they may have been exposed to some subtype of HPV, but for the others, the vaccine would still protect them. Then, if we're to talk about the still older ones, say above 25, above 30 ones, who are by now in a very stable sexual relationship, um, the vaccine may not be as efficacious as it would be in the younger adolescents. But then, if somebody demands it and they understand the efficacy, and still if they are willing to pay the money and get it done, despite our counseling that it is really not as beneficial, I don't think we have any reason to hold it back from them.
Yeah, so very clearly said, we can give, but obviously with it has to be a shared decision making, and they have to be told that it is not as efficacious as it would be in the 9 to 19 years of age group. Dr. Pratima, can you tell us if suppose HPV vaccination is done during pregnancy, whether it can be done during pregnancy and lactation, and what should we do if something like this happens? Do you have an instance?
First of all, this is subunit vaccine, so it is actually contraindicated in pregnancy. But somehow, if she has missed and she does not know and she has got vaccinated, then the termination of pregnancy is not required. And suppose she has scheduled, she was not aware, but she has not taken the vaccine and she want to know, she has now conceived what she should do. Then what we can do is we can delay that dose and that should be given after delivery. So far as breastfeeding or lactation is concerned, so patients who are breastfeeding mothers can definitely get vaccinated and they can continue feeding also because it's a subunit vaccine, it's not live vaccine, so can be given.
Yeah, so very rightly said. It can be safely given during the postpartum period and breastfeeding women, but during pregnancy it is as such contraindicated. But if somebody gets it accidentally without knowing that the person was pregnant, MTP is not required. Termination of pregnancy is not required. So thank you, Pratima. And Dr. Manjusha, another question from you. What do we do if there is a missed dose of vaccine? And sometimes we often encounter situations where the first vaccine was given from a particular of a particular company, and now she's come back again, and what do we need to do in such a situation if the same company vaccine is not available or is not given? What do we do?
Yeah. See, if somebody misses a dose, we need not restart the entire series because, as the evidence is very clear, that even a single dose is good enough. So, we may give the missed dose as soon as we wake up to it. And moreover, there is no maximum interval described in any of the guidelines. So, I personally would like to give it whenever the woman comes back for it. And the second question about a different brand, suppose if the person doesn't know which brand was given earlier, or suppose that brand is not available in that part of the world, there is no harm in giving another brand, and that would be effective enough. It's only a question of revising the immune memory, so that would not be brand related.
But then it is always advised if it is a different brand, then we need to restart the vaccination from zero. That vaccination needs to be discarded. And I may be corrected by the experts who are here, who will tell us, because this situation often arose with Cervarix. When the first dose was given by Cervarix, and now as Cervarix is being is available with difficulty, scarcity is there, and now they come and they want to be say receive either Gardasil or Sarvavac. So then we need to discard that initial first dose and restart with a new schedule. I may be corrected if somebody in the experts, Dr. Leela, could you tell us about that? And Dr. Abraham, sir, if
I
he's
would
there.
agree with Manjusha. I think, if like Cervarix doesn't have 6 and 11. So if you want to protect against 6 and 11, then you have to start all over again. But for 16, 18, since Cervarix has it and Gardasil has it, I think that should be enough.
Okay. So, Dr. Leela, can we have your opinion on this? Because this was once discussed and it was this was what the message was ultimately at the end of it.
No, I've heard both messages, but I've read it somewhere that you don't have to discount the earlier dose.
Okay, sir. Okay, sir.
Um,
So, yes, ma'am.
I was going through the WHO guidelines, and that very clearly writes that we need not start afresh. We can start from where we are.
I would
I don't know.
agree on
I
that.
stand to correction.
No, I
Okay.
agree with you, Manjusha.
Okay. So we agree for this that we do not need to restart and we can give the second dose as the patient comes now with the available
No,
vaccine.
the only
Okay.
caveat is that if they want to about warts, we don't know whether single dose is enough for warts.
Yes, yes.
So if you want to prevent warts, if that is your aim, then you may have to give at least 2 doses, 2 more doses.
Okay.
But if you're only worried about CIN, CA cervix, I think 16, 18 will prevention. That should be fine. One dose
Okay.
should be.
So, Dr. Manjusha, another question, a last question from you. Does the vaccine cause infertility? Because that's a common myth which is circulating in the society, that we had in such incidences reported in the newspaper also. And sometimes the women, they are scared and they often ask us about this. So, what does the
See,
evidence say?
logically and evidence based knowledge both indicate that vaccine is only offering you immunity. It is preventing you against HPV. It is, in fact, enhancing your ability to conceive. Because if you don't take the vaccine and you end up developing a CIN, and then you need uh, something like cryotherapy or a trachelectomy or something like that, your fertility is going to be impaired. So, vaccine would be fertility preventive rather than fertility disturbing.
So it actually does not cause infertility. That's a myth, and which needs to be the open and clear messages that it is absolutely safe.
Yes.
It does not cause any infertility.
And by now
Uh,
we have enough experience. I mean, it has been in the usage all over the world, and especially for people as young as 14, 15, it is being given, and there are no such reports of it causing any infertility. And logically also, it has no business to be causing infertility rather than protect
yes,
fertility. Yeah.
yes, very true. So, coming over to Dr. Soumya, can you tell us about vaccinating the boys? What are the pros and cons? Sir has already discussed it. So, let us discuss it from the implementation point of view. What is your take on vaccinating boys also?
So, yes, ma'am, already sir has mentioned about it, but I'll just like to clear two or three points about this. That vaccinating boys has two purposes mainly. One is prevention of HPV related cancers, which can affect the boys also, which is oral cancer, oropharyngeal cancer, head and neck cancers, anogenital warts, penile cancer, and anal cancers. And the second purpose of vaccinating boys is to create a herd immunity, which will, in indirect ways, decrease the chances of HPV transmission to girls. So, as per WHO recommendation, we can vaccinate boys before the same age group is the same, less than 15 years of age, but it forms the secondary target uh, group by WHO. So, secondary target vaccination is when we have enough resources and it's not diverting the our source system to from the primary target, we can go to the secondary target vaccination. And also, if we are getting enough coverage, more than 80% coverage to girls, then it's not cost effective to vaccinate boys. But if we are not getting this much coverage in girls vaccination, then for herd immunity, there is a possibility that vaccinating boys can add up in the cost effective way. So that is the pros and cons. So it will prevent,
Yeah.
yes, ma'am.
Yeah. So very true. The people who can afford
Mm.
in that strata of society, vaccinating boys, anybody coming and asking, we can even tell them or promote vaccinating boys. But as far as implementation from the government of India is concerned, introducing it in the national immunization schedule, I think as far as the cost effectivity would be concerned, it would be good to vaccinate only the girls targeting the 9 to 14 years or the 9 to 19 years, depending upon the resources which are available. Thank you for that, Soumya. And we go on to the next question. What I wanted from you, your opinion about HPV vaccination in CIN treated patients and patient with warts. What is your take on
Yes,
this?
yes, ma'am. It's a very important question, ma'am, because CIN treated patients, they remain at risk of further subsequent HPV infection, and then further because they have the persistent behavioral patterns which will again reinfect them with HPV, and they have their immune system or their genetic alterations. They'll all be predisposing the patients who have developed once the CIN with repeat HPV infection, either from the source, the male partner who is already HPV infected, or from auto inoculation also from the adjacent tissue. But the caution is in this, that this HPV vaccination will only be prophylactic vaccination. It's not a therapeutic vaccine. So it should be given only in the peri-treatment period. And once the HPV in directed lesion has been cured or it has been treated adequately. Otherwise, we will not know that it was a persistent infection which has already progressed, or it has been the reinfection which was there. So HPV vaccination, it should be clearly mentioned that it is a peri-treatment prophylactic vaccination, and it has shown to be 80% effective in preventing the reinfection from HPV and preventing the reoccurrence of the CIN lesions, and as well as the other HSIL, vulval intraepithelial neoplasia, and anogenital region, the pre-invasive lesions which are caused by HPV.
Yeah. So, Soumya, thank you for that. And very clearly, you have given the message that HPV vaccinating those who are under treatment or who have taken treatment for CIN. It is a prophylactic vaccine. It is not a therapeutic vaccine, but yes, it has been recommended by ACCP, as you can see in this paper, which was published in 2022. There is CDC recommendation on the same line, and they say they have given the opinion that adjuvant human papilloma virus vaccine for patients undergoing treatment for cervical intraepithelial neoplasia, and they do recommend it. The American Society for Colposcopy and Cervical Pathology does recommend vaccinating those individuals from 27 to 45 years or from 9 to 19 who have been treated for CIN, to give the vaccine that helps in taking care of any new infection for which the person has not been exposed till now. It would help in reinfecting, taking care of the reinfections. So it has been clearly recommended by ASCCP, very truly. So a word about, before we go on to Dr. Alka, could you tell us about the therapeutic vaccine? You've
Yes,
told us
ma'am.
about the prophylactic vaccination, the therapeutic vaccine.
So all the currently licensed vaccines are the prophylactic vaccine, and the therapeutic vaccines are under trial, and multiple phase 2 and phase 3 analysis have already been done, and they are under process. So we have to understand the mechanism of prophylactic vaccine, especially regarding this HPV, and the therapeutic vaccine. So the prophylactic vaccine works by invoking a humoral response or antibody response against the capsule protein of the HPV. So they target the capsule proteins and they prevent the HPV entry into the basal cells. So that is the mechanism of action of a prophylactic vaccine. But once the HPV has integrated into the basal cells and it has started producing it has regenerating particles, and E6 and E7 have started their oncoplastic role, then this vaccine is of no use. So therapeutic vaccines, their mechanism of action is to mount a cell-mediated immunity by CD4 and CD8 T cells, so that their target molecule, the target protein is also E6 and E7, not the L1 capsid protein. So E6 and E7 comes in the life cycle of HPV. Its role comes when it has integrated into the host DNA and had started multiplication. So the target protein for therapeutic vaccine is different, and it is meant to kill the infected cell, not the prevention of entry of HPV. So the available data on the therapeutic vaccines which are with us, they have shown that it is effective in the resolution of CIN2 lesions, and it can clear the HPV also from the pre-invasive lesions. So these vaccines are showing a good response, and we hope that these vaccines, when they come, they can be integrated along with the radical treatment modalities which we are using for treating cervical cancer and as well as for the pre-invasive cancers. they can be integrated along with that, the therapeutic vaccine, and along with the multiple immunomodulatory treatment also it can be combined. But till now we don't have licensed by FDA any vaccine which is available. But it is a promising vaccine. If it comes, it will maybe revolutionize the treatment part of cervical cancer.
Yeah, definitely, Soumya. Thank you so much for giving us this insight into the therapeutic vaccine. And we have now covered the clinical aspects of HPV vaccination. I would now request Dr. Alka Sharma to tell us her experience about HPV vaccination implementation from the government point of view and what should be done actually to increase vaccination and the government's role in HPV vaccination. Over to you, ma'am.
Okay, thanks, Dr. Subbohi, for inviting me for this. Am I audible?
Yes. Yeah, you are audible, ma'am. We cannot see you though, but you are audible.
Okay. Can't see me? Okay.
Yeah, we can see you now.
Okay. डॉक्टर सबोही जो एक्सपीरियंस है अभी तो वो तो जब तक गवर्नमेंट में कोई चीज स्टार्ट नहीं हो जाती मींस एज ए प्रोग्राम मैनेजर मुझे अवेयरनेस हमें जनरेट करनी पड़ेगी और अभी जब तक प्रोग्राम लॉन्च नहीं हो रहा है गवर्नमेंट ऑफ India is all set to launch the program. To launch this program, जैसे ही गवर्नमेंट ऑफ इंडिया लॉन्च करेगी उन्हें गाइडलाइंस इशू कर दिए हैं एंड ट्रेनिंग्स हो चुकी हैं और हमारा स्टेट पूरा प्रिपेयर्ड है. जैसे ही वो वैक्सीन हमें मिलता है तो वैक्सीन स्टार्ट हो जाएगा. एंड ये जो जैसा डॉक्टर अब्राहम ने बताया कि इनिशियली हम लोग 14 इयर्स की गर्ल्स को टारगेट करेंगे, दोज हु हैव सेलिब्रेटेड देयर 14th birthday but yet to celebrate 15th birthday. तो अभी वही टारगेट पॉपुलेशन है, दैट इज ऑलमोस्ट 1% ऑफ अवर पॉपुलेशन. सो उसके लिए सारी तैयारी है, वी आर ऑल सेट. जैसे ही लॉन्च होता है वो स्टार्ट हो जाएगा.
So the readiness is probably there from your side. Only thing is the government needs to introduce it and then the program needs to roll out actually. The preparatory phase is you are done with that.
Yes, even गवर्नमेंट ऑफ इंडिया ने भी कर लिया. हमारे यहाँ ट्रेनिंग, हमारे जो ऑफिसर्स की ट्रेनिंग हो चुकी है एंड हमारे स्टेट में भी ट्रेनिंग स्टार्ट हो गई है और बस वैक्सीन आ जाएगा तो we'll start.
रोल आउट हो जाएगा.
एंड जैसा मैं पहले सुन चुकी हूँ अभी हम लोग 14 इयर्स की गर्ल्स को ही टारगेट करेंगे.
जी जी.
थैंक यू. स्कूल गर्ल्स को देंगे या सबको देंगे? गांव कैसे करेंगे?
को देंगे, सबको देंगे. सबको देंगे, फेज वाइज चलेगा. सबको देंगे. बस 14 इयर्स की गर्ल को पहले करेंगे जिसका 14 इयर्स का है एंड 15 अभी नहीं हुआ है.
जो स्कूल नहीं जा रहे हैं ना उनको कैसे पकड़ेंगे?
पकड़, अब इतना बड़ा ड्राइव हमारा कोविड के टाइम पे चला है. सो मुझे लगता है वो बिगेस्ट ड्राइव था और बड़े सक्सेसफुली हो गया था. तो उसमें हमारे पास पोर्टल्स है, मींस यूविन है जो आईडी के थ्रू या तो जो कहाँ से रिबाउंड कर रहा है. ओके, लेट मी सी.
So I think due to connectivity, Dr. Alka, आप अपना वीडियो ऑफ कर लीजिए तो आपका ऑडियो बेटर हो जाएगा.
Hello, ma'am. We have already given to dropout girls in Jamnagar district, and for that there is a Kishori Yojana in the district health officer having Kishori Yojana, and in that Kishori Yojana they are having the dropout girls list of each one of each Anganwadi, and then we call the parents of that girls, we counsel them, and then we have given the vaccine to dropout girls of 10 to 20 years, a single dose.
Yeah, thank you, Dr. Alka. I would now invite Dr. Ruchi Pathak to share her experience about HPV vaccination implementation. She's been there.
Hello. So thank you for giving me this opportunity. Am I audible?
Yeah, you are, but
Hello?
with difficulty. Probably your net.
Am I audible?
Switch off your camera.
Yeah, you are audible. Dr. Ruchi, you are audible.
Okay. So thank you, Dr. Sabuhi ma'am, for giving me this opportunity. So regarding vaccination program in Varanasi, so way back in 2022, in presence of Honorable Governor of UP, some of the girls from schools were vaccinated. And though it was first time that group in vaccination was there, then the parents themselves, even before the district health officials could inform the schools, the parents themselves were very inquisitive and they wanted to know when will the second dose be given to the girls. So very recently 5,000 doses of vaccination has been given to girls from 9 to 14 years in a school based program. So it was a CSR funded project and it was very successful. So Sarva VAC was given and 2 doses has been given to 5,000 girls. Now the challenge, or like Madam just now mentioned, that for the want of vaccine, it seems that vaccination is feasible and it is acceptable to the community. Hello?
Yes, Dr. Ruchi.
Yeah. So there is community readiness and vaccination seems to be feasible. The only thing is we need to take care of the logistics. And at times I do feel that these vaccination should happen in some community clinic rather than vaccination drives taking place in school, so that we are able to manage some of the vasovagal syncope cases, though very rare.
So that is true for any vaccination, for that, not only HPV vaccination.
Right.
So any vaccination can cause that vasovagal. So the readiness has to be there to tackle that particular side effect. And that has to be kept in mind as for HPV vaccination also. So as truly said by you, I think the community is ready. What we need to now is actually roll the ball from it has to be started. The government of India needs to send the vaccines in the national immunization schedule and give us the vaccine for vaccinating in the public. Thank you, Dr. Ruchi. And now I would invite Mrs. Jaiswal. She is working in the NGO, and she's been involved with HPV vaccination implementation. And ma'am, I would like to know what is your experience about HPV vaccination. उसके बारे में आप हमें बताइए और क्या हम कर सकते हैं इसको सक्सेसफुल करने के लिए. Mrs. Jaiswal.
You're muted, ma'am.
Good evening to one and all. It was a pleasure hearing all you doctors. And thank you, Sabi ma'am, for inviting me for this panel discussion. As Dr. Uma Singh rightly said, sitting in the clinic and in your space is very easy, but working at the ground level is really challenging. And I, as the president of Inner Wheel Club Lucknow Rajdhani, last year got 365 days to work towards cervical cancer because my international Inner Wheel president, she had got this goal of working for the cervical cancer vaccination. So once you get a platform, it becomes easier to work. Now this year, the international president has changed. She has not got this, she's not given this goal. So the president this year is not working towards it. But I, as I'm a Rotarian too, I am continuing this effort and I'm working as a Rotarian too. As you all have seen, that government has worked for polio, but polio eradication was done by Rotarians. So government alone cannot do, government needs the help of we Inner Wheel members, Rotarians to eradicate this cervical cancer vaccination. And as you would say, like my experience, it was satisfying and educational, but there were a lot of challenges because when I was given the goal, so as a president, I thought, where should I target? So I targeted the school. And study hall school in Lucknow was where my children studied, so I knew that was easy access to that school. So I approached the principal, and then I kind of approached the doctor, the gynecologist, and an awareness program was created basically for the class 6 to 8 children, girls. So now the principal got only the girls, and then the target group was from 9 years to 12 years. So when the 9 years to, and I targeted the 6 to 8 children, but invited the parents too, because the children cannot take a decision whether they will go for a cervical cancer vaccination or not. It is the parents who need to be educated and aware. And when it came to the 9 to 12th group, the girls they had said, ma'am, why are you just calling us? Why not the boys are invited also? So they wanted an open discussion along with the boys. So that was one thing that helped me. And, when I conducted other sessions, so it was like, okay, the boys were also there. And as Dr. Leela ma'am said, that the right age is not targeted. And even if it is targeted, they are not, the challenge is for the second dose. Like I had gone to the police reserve line in Lucknow itself, where the commissioner's wife and every dignitaries were there. And I spoke to them in July. They had got 150 girls who were vaccinated under this CSR funding and all, 2.5 lakh mila tha, and SBIC, and they were vaccinated. The free vaccination were 150 girls got vaccinated. I had gone for a tree plantation drive, and then I told the principal, ki, ma'am, I want you to get the second dose done. They were not aware of the second dose. जुलाई में पड़ा है, दिसंबर जनवरी खत्म हो गया है, and they're not aware that the second dose has to be done. So I told them कि 8th of February, that is tomorrow, please convince the parents, the police people. Even I asked, please do something about so that they get vaccinated tomorrow. Can you believe out of 150, how many parents have only paid? Only 5. So ma'am, it is like very difficult these days. Actually, it's very big a challenge, because parents don't want, उनको लगता है कि अरे हम एक कपड़ा खरीद लेंगे लेकिन हम वैक्सीनेशन नहीं करवाएंगे. हमको मंजूर है कि हम 1000 रुपए का एक बच्चे के लिए कपड़ा खरीद लें, बट एक वैक्सीन अपनी बेटी को नहीं कराएंगे, which will safeguard her. So it's a big challenge, and I feel कि if we have to increase vaccination, 3 pillars are very much needed. Trust, बिकॉज हर पेरेंट को अपने गायनिकोलॉजिस्ट पे विश्वास है. हम और प्लस जो फेस लाइक माय डॉटर इज अ डॉक्टर, सो व्हेन आई टॉक टू देम एंड आई टेल देम कि माय डॉटर इज वैक्सीनेटेड एंड प्लीज गो अहेड, so they listen to me that time, many a time. So a familiar face, a familiar doctor can motivate them. Then you have accessibility is very much required कि आप उनको easy access दे. Like I told you, I stay in a society. कल्याण सिंह हॉस्पिटल मेरे घर के बगल में है, बट दे आर नॉट रेडी टू गो देयर, वेयर आई हैव ऑलरेडी स्पोकन टू सबोही मैम, एंड शी सेड हाँ आप आइए, आराम से हो जाएगा. दे प्रेफर गेटिंग इट डन एट द सोसाइटी इटसेल्फ. सो आई अरेंज्ड फॉर अ नर्स who came here and she vaccinated the girls. So accessibility is very much required. Also, ma'am, sorry to say, but Kalyan Singh Cancer Hospital में इतने processes हैं कि people do not want to go there. When they hear, when I tell them that आपको जाना है तो पहले पे करना है, फिर आपको जाना है तो मेडिसिन से वहां से इंजेक्शन लेना, फिर आपको आना है, दिखाना है, एंड देन अगेन आप वो वैक्सीन लेने के लिए इस जगह जाना. सो एक्सेसिबिलिटी इज वेरी मच रिक्वायर्ड. इतना inconvenience होगा, people just avoid it. So they need, parents look for convenience. That is one. And third, of course, awareness, as everybody knows कि अवेयरनेस तो करना ही है, किसी भी तरह से हम लोग को उनको बताना है, मदर्स को ज्यादा एजुकेट करना, बिकॉज एक्चुअली दे आर मोर फैमिली हेल्थ में, दे आर मोर दे कैन टॉक टू देयर हस्बैंड्स, दे कैन टॉक टू देयर फादर्स कि हाँ लाइक ऐसे है कि ये करवाना है, आई नीड दिस वैक्सीनेशन. आई हैव बीन प्रोपोगेटिंग एंड टेलिंग द गर्ल्स व्हेन आई गो टू देम कि आप अपने बर्थडे में अपने फादर से या मदर से गिफ्ट में, बर्थडे गिफ्ट में प्लीज वैक्सीनेशन अपने लिए मांगिए. दैट इज द बेस्ट गिफ्ट दैट यू कैन गिव टू योरसेल्फ ऑन योर बर्थडे. So this is what I can say, and government already, Dr. Abraham has pointed the same thing, so it would be a repetition from my end. But I have one question from Dr. Manjusha ma'am, that जिनका हम ऑलरेडी वैक्सीनेशन हो चुका है जुलाई में, जनवरी 6 months हो गया है, फेब्रुवरी है, कैन दे बी गिवन द सेकेंड डोज?
Yeah, they can be given the second dose, Dr. Tanuja ma'am.
Okay.
This is Tanuja. They can be given the second dose.
I'll be trying for that so that at least 150 girls जिनको first dose मिल गया उनको मिल जाए.
Yeah.
I'm trying for
Yes,
that.
yes, definitely. They should be given.
The recommendation is that minimum, if you're giving 2 doses, minimum of 6 months gap. You can give it after 6 months.
Okay.
Better not to give it too
So
early.
it could be February also. It can go to March also.
Yeah, it could be in the following year also.
Okay.
Yeah.
Thank you. Thank you so much.
So thank you so much, esteemed panelists, for being here, giving your time, and giving your perspective about HPV vaccination, the clinical aspect, the implementation aspect. I would like to thank all of you for coming and joining the webinar. Thank you so much.
Thank you.
So thank you so much, Dr. Subuhi, for having this very interesting webinar. And I would really like to thank all the dignitaries and the speakers for sharing such insightful information today. Dr. Abraham, thank you very much. It was a wonderful and a crisp lecture, very well moderated by Dr. Uma Singh and Dr. Leela ma'am. And Dr. Subuhi, our panel was excellent. And I must congratulate all the panelists for giving us such important messages across. And I think it is now going to be the Blinkit era for, for the vaccine, that the girls can just, just say, okay, I want to order the vaccine, and they come home with the vaccine for this is what the accessibility will improve, and I think we'll have the Blinkit era soon. So with this, I think we'll conclude the webinar today. It was a very good attendance. Almost we had 100 people joined in the middle of the webinar. And so thank you very much once again. And so we see you next month, 7th of March, everyone. And at 7 p.m., we have a very interesting topic, and we'll be dealing with cervical adenocarcinomas. And the convener is Dr. Ashok Padi from Cuttack. So see you next month. Until then, bye-bye. Thank you very much. Good night, everyone.
Good night.
Goodbye. Thank you and bye-bye.